Well, excuse me, thank you very much. I'd like to start by thanking Antonios and George for the invitation to come to Greece for this meeting. It's my second time in this wonderful country, and it's always a very, very special place because it's really the birthplace of so much that is good about Western civilization, from democracy to philosophy to theater to the history of our actual medical practice through Hippocrates and subsequent physicians in Greece. So it really is a privilege to join you for this meeting. Greek is obviously the origin as well of the word iatrogenic. And what I'm going to argue in the next probably 20 to 25 minutes is that the practice of critical illness is really the practice of iatrogenesis. And when we use the word iatrogenesis, obviously the meaning of iatrogenic is caused by the doctor. We tend to use it in a negative sense, the connotation being that something bad has happened that shouldn't have happened, that it's a medical error, that someone made a mistake, that we did less than we might have. But I think there's a much more profound sense in which critical illness is an iatrogenic state. It's not simply complications, adverse drug reactions, the unanticipated development of infection. But if you think of it, it's only been for the last probably 50 or 60 years that we have been able to keep alive the people we look after in the ICU. Prior to about 1950, virtually everyone who comes into an ICU would have died. So this slide shows pictures, for example, from the, this doesn't work, from the time of the Civil War, when soldiers were injured on the battlefield. There was really relatively little that could be done for them. Their wounds could be sutured. They could have an amputation to control bleeding. But once that was done, it was really up to the patient whether they lived or died, and that process was resolved very quickly. Death was never prolonged. It would take a matter of hours for a patient to die, or equally a matter of only days for a patient to get better. The other photograph shows the influenza pandemic of 1918. And this was a pandemic that took the lives of about 40 million people around the world. Today, the death toll would have been substantially less because there was really nothing that could be done for victims of influenza apart from isolating them in locations where nurses could come and give them liquids, maybe wipe their fevered brows, and give them comfort. But beyond that, there really was nothing that could be done to specifically treat influenza. And again, you either got better from the disease or you died of the disease. We changed that in the 1940s and the 1950s, and as a result of changing that, we created intensive care units. Obviously, one of the major advances that led to the development of the intensive care unit was the development of positive pressure mechanical ventilation, shown here in the polio epidemic in the early 1950s in Scandinavia, the first use of mechanical ventilators. And what the mechanical ventilator did, it has allowed a patient who otherwise would have died a rapid and peaceful death to be kept alive longer. And once they were kept alive longer, they became subject to a whole series of complications that are simply unprecedented in medicine. And this is the picture that we see today of a critically ill patient in an ICU. Someone who is really almost suspended between the state of life and the state of death and kept there by virtue of a number of artificial devices that are supporting blood pressure, supporting ventilation, supporting nutrition, administering a broad variety of medications. So critical illness is an iatrogenic disorder because it only develops in the survivors of acute life-threatening illness. These are patients who in an earlier era would have died, and it is only because we have been able to intervene to save their lives that they become susceptible to all of the complications that occur in the intensive care unit. So in one sense, we can talk about critical illness as being iatrogenic in its being a success of our ability to, if not ultimately prevent death, at least delay it longer so that the patient has a greater chance of being able to survive. And as a result of having done that, we have created a series of diseases that simply have no precedent in medicine. It was not possible to develop ARDS prior to the advent of mechanical ventilation because, of course, acute respiratory failure was gasping respirations that lasted for perhaps a maximum of half an hour and terminated in the patient's death. And so the first intensive care unit was developed in the late 1950s, and the first report of this ICU syndrome of acute respiratory insufficiency appeared in 1963 when a group in Boston described what they called high-output respiratory failure, and they ascribed this to peritonitis and the response to peritonitis. 4 years later, Ashbaugh and Petty described this as the acute respiratory distress syndrome, and it's one of the dominant syndromes of the intensive care unit. But again, it did not exist prior to 1960, could not have existed prior to 1960 because it required the intervention of the mechanical ventilator to exist. Septic shock is another one. We are all very familiar with the clinical syndrome of septic shock, but it was only described again in the 1960s and again after the development of the intensive care unit, because septic shock became possible when antibiotics and perhaps more importantly fluid resuscitation enabled patients who would have died fairly rapidly from overwhelming infection to survive longer. And of course, the classical hemodynamic profile of septic shock is a reflection not so much of the underlying insult, but of the fact that the patient has been resuscitated and therefore is able to develop a hyperdynamic circulatory state. So again, this is an iatrogenic disorder that has no precedent in medicine and has only been with us for many of us the course of our lifetimes. So I think this was probably best expressed by the late Arthur Bowie, who was a surgeon from the United States who was responsible for the concept of multiple organ failure. Bowie said that the limiting factor after injury in patients who don't have a brain injury is not any one single system. Remember that in the 1960s, in addition to septic shock and ARDS, we were seeing descriptions of stress bleeding, of disseminated intravascular coagulation, of acute renal failure, again, all sorts of diseases that required medical intervention to describe. And what Bowie said is that what limits the survival of the critically ill patient is not any one failing system, but actually the interaction of multiple failing systems. And he termed that multiple systems failure. Other people have used the word multiple organ failure or the multiple organ dysfunction syndrome. But it really is the embodiment of the successes and the failures of modern critical care. But that's maybe the good side of critical illness as an iatrogenic disorder. Critical illness is also iatrogenic because the very interventions we use to keep patients alive cause further injury. And the extent to which we don't recognize the potential downside of what we do, we are unable to deal with some of the barriers that limit the survival of critically ill patients. So if you look at this young man, this was a young man who had a pneumococcal pneumonia. You'll appreciate that he is kept alive by CVVHD. He's on a mechanical ventilator. We even had him on plasmapheresis to try to remove undefined toxins from the blood. But multiple different interventions are involved in the process of keeping him alive. These same interventions start to shape the phenotype of the disease after he's been in the ICU for a day or two. So we can really think of the state of critical illness as being the intersection between three different processes. Obviously, there is the initial insult that brought the patient into the intensive care unit. It may be infection, it may be shock, it may be multiple trauma. But once the patient has been in an ICU for 24 or 48 hours, I would argue that none of us can look at that patient and tell you what the inciting insult that brought them into the ICU was, because they begin to look very much like a critically ill patient. And that state of critical illness is driven by two things. One is the innate immune response of the host and all of the things that happen endogenously in response to infection. But the other one, and the one that we probably have the least understanding of, is all of those things that the doctor does to try to to salvage the patient and that may or may not cause further injury. So let me just amplify this by looking at a couple of areas where clearly iatrogenesis becomes part of the syndrome that we treat. I don't think anybody here would disagree with the concept that fluid resuscitation is one of the big advances of the 20th century. We're all familiar with the work of Manny Rivers, who really kind of protocolized the concept of early goal-directed resuscitation. And he showed that if you resuscitated a patient early and aggressively in the emergency department, you could improve their survival rate by 16%. You could avoid a lot of the sequelae of shock and tissue hypoperfusion. But we're also familiar with this paper by Kath Maitland, which was done in a very different kind of environment. This was done in rural Kenya, and she had hypothesized that if fluid resuscitation is beneficial to critically ill adults in Detroit, Michigan, surely that same principle must apply to critically ill children with malaria in Africa. And what she found, lo and behold, was that when you resuscitated children with severe malaria, their survival was actually worsened. And that may seem counterintuitive until you realize that the sequelae of resuscitation, acute respiratory failure, couldn't be dealt with. And so by giving patients intravenous fluids, you were setting them up for the next challenge, which was respiratory insufficiency in an environment where there didn't exist the capacity to support that. And so I think we're beginning to realize that fluid resuscitation, like everything we do in the intensive care unit, is a double-edged sword. It's beneficial, and it's particularly beneficial if used early on, but it becomes part of the problem subsequently through the development of tissue edema. Indeed, if you think about the problem of acute respiratory distress syndrome, it in its earliest phases is simply permeability edema in the lung resulting from a combination of the inflammatory response in the lung and the doctor administering large amounts of fluid to support the circulation. But edema plays multiple roles, and I'll elaborate on these. It also has associations with adverse clinical outcome. These are data from the Canadian VAST trial looking at the association between fluid balance and clinical outcome. And what John Boyd, who was the author of this paper, did is he divided patients in the trial into 4 quartiles on the basis of the amount of fluid they received over the first 96 hours. And what you see is those patients who were in the lowest volume resuscitation quartile had the highest survival rate. Those who received the most fluids had the worst survival rate. And in fact, you can see that what we do over the first 48 or 96 hours in the intensive care unit is actually quite remarkable. Here is the patient at baseline being resuscitated from septic shock, receiving perhaps 6 to 7 liters of fluid over that time. But look what happens over the first 4 days. The extremes of fluids go up as high as 15 liters, and there's another liter or 2 liters that's administered following resuscitation from shock. And the administration of that fluid is associated with an adverse outcome. Now, of course, this doesn't imply causation. It could simply be that the physiologic state that caused the doctor to give more fluid was responsible for mortality. And often it's very difficult in the ICU to disentangle what is patient illness and what is clinical decision. But there are some nice observational studies on this. This is one that suggests that, in fact, in critically ill patients, a combination of aggressive early fluid resuscitation and a conservative post-resuscitation strategy is associated with the lowest mortality rate. If you have adequate initial resuscitation and give lots of fluid, the mortality rate almost triples. If you have inadequate resuscitation but conservative fluid resuscitation, again, there's an increase over adequate fluid resuscitation. And the very worst situation to be in is being inadequately resuscitated and subsequently treated with a liberal fluid resuscitation strategy. So There are indeed a couple of randomized controlled trials that have also established the concept that although fluid is beneficial in the early resuscitative phases, a more conservative strategy is beneficial later on. These are data from the ARDSNet FACT trial showing that you can reduce the time on the ventilator and reduce the length of time alive and outside in the ICU by a more conservative fluid management strategy. So we're becoming aware that edema in critically ill patients, something that certainly in my own practice I've kind of thought of as simply being one of the inevitable sequelae of appropriate care, is in fact part of the phenotype and part of the problem as it evolves in the intensive care unit. Edema has consequences in virtually every organ system. It's responsible for changes in mental status, because of subclinical edema in the brain. It's responsible for alterations in myocardial function, for impaired gas exchange, for renal dysfunction, and even for cutaneous problems such as the development of pressure sores. And then edema as well contributes to ileus and an inability to tolerate enteral feeds. So there's an example of a situation where a life-saving intervention in the intensive care unit becomes the next threat that the patient faces, and we have to appreciate that. We use vasoactive therapy when we can't get the blood pressure up, but there are downsides to vasoactive therapy, and I want to just show you one. This is a study that looked at the consequences of the use of vasoactive therapy on anastomoses in the gastrointestinal tract. And so the authors reviewed more than 200 patients who'd had GI anastomoses and showed that the use of vasopressors was associated with an increased risk of anastomotic leak, and that was independent of the blood pressure or the indication for which vasopressors were administered. Indeed, I have not been able to find compelling evidence that vasopressors are beneficial, but certainly they are widely used in critical care, and one of the consequences is alterations in blood flow that can contribute to problems. So they're probably another one of these double-edged swords that we use in the intensive care unit. Transfusion is another good example of that. These are data from the Canadian TRIC trial, which we undertook with the hypothesis that we anticipated showing that a restrictive transfusion strategy would be equivalent to the conventional, more liberal transfusion strategy targeting a hemoglobin of 100. We thought our major benefit would be in showing that we can get away with less blood use. But indeed, what we found in the TRIC trial was a strong trend towards a mortality benefit for a restrictive transfusion strategy and a significant reduction in organ dysfunction in those patients who are managed conservatively. So in a bleeding patient, we would all administer blood, but there are consequences of doing that, and transfusion is another component of the iatrogenic character of critical illness. Mechanical ventilation, I think, is probably the best understood, thanks to the work of a number of people, including Luciano Gattinoni, Art Slutsky from our institution in Toronto. We've begun to understand that the phenomenon of the acute respiratory distress syndrome is not simply a disease of the lung, it's a disease of the way we care for patients who are on mechanical ventilators. And fortunately, these kinds of CT scans are distinctly less common, but I remember being struck by this when we first saw what the lung of a patient with ARDS looked like. On a plain film, you saw diffuse bilateral fluffy infiltrates, but on a CT scan, you saw the consequences of our ventilation and nursing strategies with posterior dependent consolidation of the lung, and in the anterior antidependent zones, extensive cyst formation because of overdistension of the lung and damage of the alveoli. And so this led to the notion that ARDS is not just a disease of the lung, it is also ventilator-induced lung injury, and pointed to a strategy that could be used to try to attenuate the iatrogenic components of that injury. Indeed, the effects of injurious mechanical ventilation are really systemic effects. This was a study done by Yumiko Imai in Toronto, where she used a rabbit model of mechanical ventilation and showed that using a strategy that overdistended the lung in the absence of PEEP and caused ventilator-induced lung injury, one of the consequences of that was actually the induction of apoptosis in renal epithelial cells. And when she measured creatinine levels, their creatinine levels were elevated in those animals who'd had injurious ventilation strategy. So this iatrogenic injury to the lung translated into further injury to remote organ systems. And so it's a nice paradigm for the concept of multiple organ dysfunction syndrome. And the importance of it is that once one is aware of the inadvertent sequelae of what one does, one can design strategies that attenuate those consequences. And these, of course, are the data from the ARDSNet study, the ARMA study, looking at using a lung protective strategy to avoid overdistension of the lung, showing that the mortality rate could be dropped by approximately 9% by the use of lung protective ventilation. And as we heard yesterday, we're increasingly moving to more sophisticated models of lung protective ventilation, including high-frequency oscillation. All because of the fact that we've appreciated that the lung is not a passive bystander in the process of critical illness, but actually an active player and an agent of that critical illness. So one can look in many, many, many different systems, and I'm not going to go into this in any particular detail, but bed rest and sedation, something that we do because we believe that patients will be better off if we try to alleviate their suffering and keep them quiet in bed for a while, has adverse consequences. These data from Jesse Hall's group in Chicago showing that if you employed a strategy of deliberately waking patients and providing them with a sedation vacation, you could shorten the duration of mechanical ventilation, you could shorten the ICU stay, and there was a trend that was almost significant towards getting the patients out of hospital more. In other words, reducing the hospital mortality rate. Certainly, you minimize the risk of other iatrogenic complications, such as ventilator-associated pneumonia, if you temper your concern for the patient's comfort with a recognition that in the long run, there's really nothing ideal about being heavily sedated on a ventilator for a prolonged period of time. Systemic antibiotics are another area. We know that antibiotics play a critical role in killing bacteria, and that critical role early in the course of an infection is associated with a better clinical outcome. These data from Anand Kumar showing that the longer one delays the institution of appropriate antibiotics in patients with septic shock, the worse the survival is. But the corollary does not hold that giving large numbers of antibiotics is without adverse consequence. This was an observational study that we undertook several years ago where we looked at a cohort of about 500 patients who were enrolled in a study of patients with suspected infection. And we looked at the risk factors for death in this population. And as you see, the ones you might anticipate showing up do so. Older patients were more likely to die. Patients with significant medical comorbidities were more likely to die. Severity of organ dysfunction was a risk factor for death, as was the use of vasopressors. Intriguingly, in this population of patients with suspected ICU-acquired infection, the actual diagnosis of infection didn't actually increase the risk of mortality. But when we looked at those patients who were ultimately adjudicated not to be infected in that cohort, so these are patients who are suspected of harboring an ICU-acquired infection, who ultimately were shown not to be infected. Again, we could see the determinants of mortality included age and the development of organ dysfunction. But we looked at those patients who, in the absence of infection, had antibiotics continued for more than 4 days. And as you can see, there was an odds ratio for increased risk of death of 5.5 times that was almost statistically significant in those patients who had their antibiotic exposure prolonged in the absence of a documented focus of infection to treat. And of course, we are aware of the many potential adverse sequelae of indiscriminate or even appropriate antibiotic use. One of the major ones in intensive care units now being the development of Clostridium difficile colitis, which carries substantial morbidity in its own right. If you look at the characteristic bacteriology of infections in critically ill patients, they're caused by organisms that share certain features, and two of these reflect the iatrogenic character of critical illness. First of all, these organisms are organisms that are selected for by the use of broad-spectrum antibiotics, and therefore emerge because the gut becomes colonized with these in patients with who are on broad-spectrum antibiotics. But the other feature they carry they share is that they tend to grow in biofilms, and so they live on invasive devices such as intravenous catheters, Foley catheters, and endotracheal tubes. And so a consequence of our monitoring is setting the patient up for infection. Indeed, the whole concept of ventilator-associated pneumonia doesn't make sense in the absence of a ventilator. One has to be on a ventilator to develop ventilator-associated pneumonia, and it is therefore an iatrogenic complication. So I just want to conclude by what I'm trying to put forth here is the concept that in critically ill patients, what we do becomes part of the disease process, and it really behooves us to pay attention to what the next barrier to success is in critical care. It is likely something that we are doing, and it is likely something that we feel passionately is the right thing to be done for that patient. Because there is absolutely nothing adaptive about the state of critical illness. Human beings do not reproduce on ventilators, and as a result, there is nothing about the state that we see in our patients that would give them a survival benefit, and therefore that would be somehow enriched in the human genome. The phenotype, which is a common phenotype regardless of what the disease that the patient came into the ICU with, is actually a reflection of the technology we use to support the patient rather than the disease they came in with. And because of that, we have to focus our research on strategies to try to minimize the adverse consequences of an intervention while at the same time maximizing its benefits. Thank you very much for your attention.